low prevalence of familial HCM. So efforts to improve diagnostic and treatment options in India have highlighted the need for dedicated hypertrophic cardiomyopathy centers to address underdiagnosis and disease burden. These are all the studies in our country which show the prevalence and discovery and understanding of the HOCM. Earlier description started from the 19th century when Heloppo and Levy described the first findings compatible with HOCM, and in 1952 Davis reported familial relation of that with sudden deaths, and in 1958 Thierry identifies asymmetric septal hypertrophy and myocardial fiber disarray in sudden deaths. Clinical advances and then named as hypertrophic cardiomyopathy by HOCM by Goodwin. In 1970, echocardiography detects ASH and a systolic anterior motion of the mitral valve. HCM identified as genetically transmitted, both obstructive and non-obstructive forms. Evaluation. Initial attempts were 1957 to 59, where Brock reports surgical attempts. Early approaches include simple myotomy, and Mayo Clinic introduced introduction of myectomy via left ventriculotomy. Techniques by Lillihei, Levy, and others involve mitral valve intervention also. And modern techniques involve Morris procedure, standard myectomy via aortic approach addressing LV outflow obstruction. Non-obstructive HCM focuses on diastolic dysfunction, reduced LV compliance. Genetics and imaging now guide personalized management. Coming to pathology and pathogenesis. So genetic basis, this is caused by missense mutations in at least 11 sarcomeric protein genes. Mainly we have to remember this beta myosin heavy chain, which is in the chromosome number 14, and cardiac troponin T1 and alpha tropomyosin chromosome number 15. Mostly transmitted as autosomal dominant through non-familial, though non-familial cases also may occur. Variants of hypertrophy, echocardiac classification, though seldomly used these types, but it was described type 1, type 2, type 3, type 4, where type 1 hypertrophy of the anterior ventricular septum, and then type 2 is entire septum involved. Type 3 is involvement of free wall and septum. Type 4 is hypertrophy of non-septal areas. So pathologically, the LV wall thickness will vary from 13 to 15 mm, which is mild, to greater than 50 mm, which is very massive. These are the images showing different types of hypertrophy, where here see reversal curvature one, which forms a crescentric LV cavity shape here, which is a neutral one. That means anterior septum is involved, where right septum can be seen in the echo. Sigmoid one, where the base of the septum will be involved, which form the ovoid shaped LV cavity, and apical hypertrophy, here apex is involved, which show clover ace of speed cavity. So general features, hypertrophy varies in location and severity, and primarily affects the interventricular septum and left ventricular. So mostly in most of the cases, it is called a classical HOCM, where hypertrophy is maximal at the cephalad septum, just apical to the anterior mitral leaflet. There will be fibrous endocardial plaque forms due to the contact between the anterior mitral leaflet and the septal bulge in diastole. Midventricular hypertrophy, where maximal thickness near papillary muscles, it will lead to the midventricular obstruction, which is causing midventricular gradients. So here there is no SAM or mitral regurgitation happening in midventricular hypertrophy. And localized apical will be mostly seen in the Japanese people. And then hypertrophy also involve posterior septum and sometimes anterior septum, which are of rare cases. Coming to dynamic morphology of the septum and mitral valve. So in classic septal hypertrophy, LV outflow tract between the hypertrophied septum and anterior mitral leaflet, the coaptation of the mitral leaflets, posterior leaflets close against the elongated anterior leaflet in the midsection, not near the free edge because of the elongated anterior leaflet, and then free edge of the anterior leaflet hinges cephalad towards the aortic annulus, contacting the free septum. Then happens the systolic anterior motion, which is a constant feature of classic HOCM. Degree of SAM correlates with severity of obstruction and diameter of the LV outflow tract. Occurs during early systole, related to rapid ejection and peak LV outflow gradients. Primary mechanisms are the forward displacement of the mitral valve, and Venturi effect, which is the high velocity blood which pulls the anterior mitral leaflet towards the septum. So secondary effect of elevated pressure below the anterior leaflet forces it further to the LV outflow gradient, further to the LV outflow tract. So this is the image showing how the systolic anterior motion leaflet will occur. Here, this is the normal leaflet where the point of coaptation of the mitral valve will be tethering to the towards this side. But because of the decreased tethering force and then increased Venturi effect here in the outflow gradient, this elongated mitral anterior leaflet of the mitral valve will get pulled towards the septal bulge. Left ventricular cavity in HOCM. So mostly, which I have shown previously, cavity depends upon the type of hypertrophy which is involved. Mostly like sigmoid dumbbell shaped and sometimes confined to the apex, and some if confined to the apex, some midventricular cavity LV apex may get weakened and cause LV apical aneurysms. Only in 2% cases we can see that. And late stage transmyocardial infarction. Transmural myocardial infarction also causes severe progression of hypertrophy without heart failure, with or without heart failure, associated with poor prognosis and refractory cardiac failure. These are just showing pathological images where we can see hypertrophic cardiomyopathy of the left ventricular fever also here with cross-sectional images, which involved the septum and then apex also. So histopathology of the left ventricle in hypertrophic cardiomyopathy. So wall thickening primarily due to increased fibrous tissue and increased muscle diameter with large diameters closer to the cavity, highest wall stress. Microfiber disarray, disarranged muscle cells, which is about 30% in hypertrophic cardiomyopathy. In other conditions, it will be only 1.5%. In obstructive hypertrophic cardiomyopathy, disarray confined to the mostly to septum, but in non-obstructive hypertrophic cardiomyopathy, LV free wall also disarray will be seen. So clinically, why it is important is forceful LV contraction with rapid early ejection and impaired compliance and relaxation cause prolonged early filling phase, decreased rapid filling rate, and increased reliance on atrial systole for LV filling. So this is a histological image showing microfiber disarray in H&E stain slide, and here it is Masson's trichome slide demonstrating fibrosis in this area. So this all blue color is the fibrosis. Mitral valve in hypertrophic cardiomyopathy. In closer position of the mitral valve to the septum, mitral valve will be closer to the septum in these conditions, and then elongated and thickened leaflets, and there will be pursuing action of the mitral annulus during systole creates leaflet folds, and systolic anterior motion, which we have already explained, that is correlates with the pressure gradient, prolonged LV ejection time, and duration of mitral leaflet and septal contact. Other than that, around in 20% of the cases, we can see independent mitral regurgitation related to other conditions. Right ventricle. So chamber distortion will happen in hypertrophic cardiomyopathy. Hypertrophied ventricular septum projects into the right ventricular outflow tract, results in a pressure gradient, and in severe cases, right ventricular fever hypertrophy also starts. So because of it, the secondary effects like pulmonary hypertension due to chronic left-sided heart failure also affects right ventricle, and elevated left atrial pressures also involved. Histological changes, same histological changes like fibrous tissues and myocell diameter increasement, and then disarray can be seen. Clinically, it is relevant because right-sided involvement reflects the systemic impact of the hypertrophic cardiomyopathy and may exacerbate overall hemodynamic burden. And the prognosis will be bad if right ventricle also involves. And then coronary arteries, structurally coronary arteries are larger in diameter than normal, and wall thickening with the luminal narrowing in intramural coronary branches, common in the ventricular septum and occasionally in free walls. Found in 50% of the hypertrophic cardiomyopathy patients, more frequently than in other forms of hypertrophy. LAD per se anomalies are muscular bridging, Systolic occlusion or sawtooth appearance may occur in the LED, and septal perforating arteries may narrow and obliterate during systole. So, which causes myocardial ischemia. Possible mechanisms are systolic arterial compression or spasms or narrowing. Inadequate capillary density and reduced diastolic coronary flow due to impaired ventricular relaxation. Clinical implications are transmural myocardial infarction may occur in hypertrophic cardiomyopathy despite the absence of significant coronary arteriosclerosis. These are the histological images showing the changes in coronary arteries. HND and Manson trichrome showing adventitial scarring with the thickening of dysplastic media. Just for completion, there will be some associations in hypertrophic cardiomyopathy like diffuse lentiginosis and hypertension. Other associations like congenital or ASD and rheumatic heart disease, and one more is von Willebrand factor dysfunction, which is seen in obstructive HOCM, closely related to outflow obstruction when resting pregradient greater than 15 mm Hg, may lead to abnormal spontaneous bleeding. Coming to clinical features, symptoms common are angina, dyspnea, syncope, and dizziness. Palpitations often from the atrial fibrillation, which is 10% in late stages. 10% of the patients will be permanent AF in late stages, and arrhythmias, when VTs, premature beats, and supraventricular tachycardias can happen. And in advanced stages, heart failure like orthopnea, PND, pulmonary edema will happen. Rarely, if right-sided also heart failure occurs, then ascites, peripheral edema with tricuspid regurgitation also starts. All these symptoms are driven by mainly diastolic dysfunction and arrhythmias and myocardial ischemia and left LV outflow gradients. Signs. Coming to signs, late ejection systolic murmur with maximal between the left sternal edge and the apex increases after Valsalva. We can see the difference between the murmur of AS and HOCM with Valsalva standing and with squatting, where in HOCM with standing the intensity of the murmur increases, and after squatting the intensity of the murmur decreases. With AS it is the other way, where when standing intensity reduces and in squatting intensity increases. It's all related to the increase in preload afterload, where if preload is more, if afterload is more, then AS murmur will increase. If preload is more, then HOCM murmur will reduce. The other classical sign is bifid arterial pulse, so that is rapid upstroke and then spike and dome. That means there will be a spike and then dome. Whereas in AS it is pulses parvus with slow steady rise in the pulse is the feature in AS. And palpable left atrial contraction, sometimes described it as a double apical impulse. And additionally, third and fourth heart sounds and paradoxical splitting of S2. No aortic ejection click or valvular calcification things can be heard. And cyanosis in infants due to left to right atrial shunting can be seen sometimes. So, natural history of hypertrophic cardiomyopathy. Clinical spectrum. Familial HCM includes isolated ASH and HOCM, both with similar genetic implications. So progression will be rare for isolated ASH to progress to obstructive HCM after the age of 20. So till 20 it will be progressing. After 20 rarely it will continue to progress in familial one, and rapid progression in infants and young children, often with severe hypertrophy, heart failure, and sudden death. Clinical course typically stable over long periods. Adverse events include heart failure, syncope, sudden cardiac death, and embolization. Atrial fibrillation often precipitates heart failure and embolization. Usually, this kind of sudden cardiac death, syncope, and embolization, these three are the three main things which with the patients present. Symptom correlation, degree of obstruction does not always correlate with symptoms, and NYHA class 3-4 usually have the gradients greater than 100 mm Hg. Mortality rates annually in children in a referral centers, it is 4 to 6%, in adults is 2 to 4%, but in unselected normal patients it is 0.5 to 1.5, which is similar to general population. So risk factors for sudden death, which we will see further later, and then other causes of death will be cerebral embolism, which is linked to atrial fibrillation. And in a study over 5.2 years, we can see 23 deaths are from sudden cardiac death only one from heart failure and 2 from endocarditis. So this evaluation on prevention of the sudden cardiac death will make a difference in this patients. Coming to approach to diagnosis, usually starting from the chest X-ray. So chest X-ray doesn't show any classical findings. Only we can see mild to moderate cardiomegaly and small aorta, pulmonary venous hypertension or interstitial edema can be seen due to raised left atrial pressure. And then rhythm analysis and HOCM, usually in ECG, we can see LV strain pattern, and then Q waves may be present because of myocardial infarction, and then bundle branch blocks, complete or left bundle branch or left anterior hemi block can be seen. Giant negative T waves in V4 to V6, typical in isolated apical hypertrophy, and left atrial enlargement is common, right atrial enlargement is less frequent. To recommendations for heart rhythm assessment in hypertrophic cardiomyopathy. As part of routine heart rhythm monitoring, initially 12 lead ECG will be done, and then periodically follow up for every 1 to 2 years is recommended. And then ambulatory ECG, which is over 24 to 48 hours monitoring during initial evaluation and periodic follow up every 22 years to identify sudden cardiac death risk and manage arrhythmias. That is for initial and periodic ECGs. Extended monitoring and screening, symptom driven monitoring, usually whenever there are palpitations or lightheadedness, we have to do 24-hour ECG monitoring or event recordings. First degree relatives of your diagnosed patient will be done 12 lead ECG. And in high risk patients, extended ambulatory monitoring, where monitoring will be more than 48 hours. In high risk individuals identified by risk factors or validated risk scores, patients eligible for anticoagulation, which is conducted annually and at initial evaluation. Asymptomatic patients without risk factors, they will be evaluated only if there is a suspicion of asymptomatic paroxysmal AF as part of initial evaluation, and then every 1 to 2 years. Echocardiography in hypertrophic cardiomyopathy. Echo is the cornerstone of diagnosis, offering structural, functional, and hemodynamic insights. Mostly, it is guiding it's a guiding one for the diagnosis also, and then to the management also. In M-mode echocardiography, which is having high temporal resolution, we can measure the thickness of the wall, typically greater than 1.5 centimeters, and systolic anterior motion we can see, and then premature aortic valve closure also. Severity of the SAM correlates with LV obstruction and then LA size. In 2D echo, mitral valve abnormalities can be seen, and apical aneurysms and LV non-compaction differentiation we can make out. And Doppler echo, hemodynamic and physiological insights can be seen, where color Doppler shows turbulent flows, pulse wave shows blood flow velocities and location of the obstruction, and then continuous wave Doppler quantifies the LVOT gradient. And specialized imaging, there are some specialized imaging in echocardiography like contrast echo, where it is done whenever it is needed, and transesophageal echo, mostly it is done in intraoperative guidance, in intraoperatively and for mitral valve assessment. And exercise echocardiography identifies a latent LV outflow obstruction in symptomatic patients without resting gradients. Usually in rest 4 mm Hg, in post exercise it is increasing to 45 mm Hg in a study with a median of 30 mm Hg. So 52% of the patients develop gradients greater than 30 mm Hg, and 38% of the patients reaching greater than 50 mm Hg. So this is all the study which are not having any outflow obstruction in resting. So upon exercise testing, this many percent of the patients are having gradients. And differential diagnosis mimics athlete's heart, hypertensive heart disease, and cardiac amyloidosis. Key features are hypertrophic cardiomyopathy, systolic anterior motion, and asymmetric hypertrophy, LV obstruction. But in amyloidosis, it is biatrial dilatation, restrictive inflow pattern will be there, and then apical sparing will be there. Recommendations of echocardiography. Usually all suspected patients will have an initial evaluation of echocardiography, and then like ECG, we have to follow up with routine follow-up every 1 to 2 years, and then whenever there is any clinical status change, we have to do echo, and then provocative maneuvers will be recommended when the LVOT gradients are less than 50 mmHg, which is level 1 indication. And then exercise testing is recommended when for symptomatic patients without significant gradients, exercise transthoracic echo is recommended to detect dynamic LVOT. And procedurally, we will do transesophageal echo to see the adequacy of myectomy while doing procedure, and in alcohol septal ablation also we will use. Post septal reduction, it is done after 3 to 6 months to evaluate the procedural results. And then screening for family members, transthoracic for first relative, and then genotype positive, phenotype negative individuals, it is 1 to 2 years in children and 3 to 5 years in adults. Alternative imaging is use of TE useful if transthoracic is not inconclusive, and if we have apical hypertrophy to see and apical aneurysm, we can use contrast images, and only if cardiac MRI is not is unavailable or contraindicated. And in asymptomatic patients, exercise transthoracic echo is reasonable to detect dynamic LVOTO in those without significant resting or provocable gradients. Echo image showing obstructive hypertrophic cardiomyopathy, where this upper one showing color Doppler with turbulence with mitral regurgitation, turbulence in the LVOTO and mitral regurgitation here, and then lower panels shows this is the midventricular hypertrophy, which is showing midventricular gradient, midventricular obstruction. So cardiac magnetic resonance imaging applications in hypertrophic cardiomyopathy. Role of CMR is it's a gold standard for quantification of ventricular size, mass, and function. Differentiation of hypertrophic cardiomyopathy from other causes of hypertrophy, and then 3D assessment is possible in this. Assessment of LV morphology and function. Using Simpson's method, they will calculate volumes of the volumes of the heart, and then ejection fraction and systolic volume, and then we can measure ventricular mass excluding the papillary muscles, and then diagnostic criteria is septal thickness greater than 15 mm, and then septum to lateral wall ratio greater than 1.3, or if it is hypotensive case, it is greater than 1.5. Specialized applications are mitral valve and papillary muscles, where abnormalities like elongated leaflets and systolic anterior motion or direct insertion of papillary muscles into the mitral valve can be seen, and myocardial strain and fibrosis. MR tagging and T1 mapping. MR tagging, usually we can see myocardial strain and deformation, and then T1 mapping quantifies fibrosis, where usually it is described detected by late gadolinium enhancement, LGE, but in T1 mapping we can detect early stages of fibrosis. Risk stratification with LG and ischemia. This thing called late gadolinium enhancement, which detects fibrosis, is important for risk stratification for sudden cardiac death. So detecting fibrosis in areas of hypertrophy or wall motion abnormalities extent greater than 15% LV mass predicts higher risk for sudden cardiac death. Myocardial ischemia detected with stress perfusion imaging signifies microvascular obstruction linked to adverse outcomes. So differential diagnosis we can make out with the hypertrophy like hypertensive heart disease, athletes and ventricular non-compaction. Advantage is the high spatial resolution and then reproducibility. Differentiates between hypertrophic cardiomyopathy phenotypes and mimics and guides therapy planning and especially for septal reduction therapies. Here we can see the late gadolinium enhancement in the anterior wall of the LV. You can see here this apex MRI images showing the apex having aneurysm thinned out with the late gadolinium enhancement, which is showing the fibrosis of the apical area. So recommendations is echocardiography if it is inclusive, inconclusive, then MRI is indicated, and differential diagnosis if we are not able to make out in echo, it's recommended. And risk assessment for sudden cardiac risk stratification in uncertain ICD candidates. So evaluate maximum LV wall thickness, EF and apical aneurysm and myocardial fibrosis. In procedurally identifies pre-procedurally we can do to clarify anatomic mechanisms of obstruction and septal reduction therapy planning. Monitoring every 3 to 5 years, but it is recommended as 2B. So mostly it is echo only in some patients, sometimes can be used for periodic monitoring. Cardiac catheterization and cine angiography. Current role is less commonly used due to high accuracy of echocardiography. Only reserved for inconclusive echo or suspected coronary artery disease, and if you are planning for septal reduction therapy or pacemaker or transplantation. Key findings are right-sided catheterization identifies infundibular stenosis and elevated pulmonary arterial pressures, and left side measures LV and diastolic pressures, localizes obstruction, avoiding apical entrapment to prevent falsely high readings. Dynamic obstruction with provocative maneuvers like Valsalva exercise can be seen while doing a cath study. And cine angiography, left lateral view preferred for imaging with LV outflow with tract and septal bulge, which demonstrate a systolic anterior motion and degree of mitral regurgitation. Key observations are spike and dome pulse counter, and which reflects the dynamic LV outflow obstruction. Recommendations are only in invasive hemodynamic assessment. When the non-invasive imagings are inconclusive, then only it is recommended. And in myocardial ischemia, where symptoms or evidence of myocardial ischemia are there, then it is indicated. And then as a part of pre-surgical evaluation, where patients are undergoing septal myectomy, CAG. Clinical sudden death risk factors. Coming to risk factors in adults and children. Family history. First, family history of sudden death definitively or likely attributable to hypertrophic cardiomyopathy in greater than 1 or equal to 1 first degree or close relatives. And then multiple sudden deaths in extended relatives, which is secondary or tertiary degree, are also relevant. And then massive left ventricular hypertrophy, wall thickness greater than 30 mm, and then borderline values like greater than 28 mm may be considered at cardiologist discretion. For pediatric patients, wall thickness correlating to G-score of greater than 20 is recommended. And then unexplained syncope, greater than 1 episode of acute transient loss of consciousness, judged unlikely to be neurocardiogenic, that is vasovagal, not caused by LVOTO, and most relevant if occurring within 6 months of evaluation. And then LV systolic dysfunction, which is LVEF less than 50, LV apical aneurysm, discrete thin-walled dyskinetic akinete subdued with a transmural scar or LGE, and independent of the size, any apical aneurysm is a LV apical aneurysm is a risk factor for sudden cardiac death. And extensive LGE on CMRI, that is already we have seen greater than 15% of the LV mass, and non-sustained ventricular tachycardias, that is greater than 3 beats at greater than 120 beats per minute frequently or prolonged runs confer greater risk. Greater than 10 beats or greater than 200 beats per minute particularly concerning. And then for children, VT exceeding the baseline sinus rate of greater than 20% is significant. Genotype positive status, pathogenic or likely pathogenic variants associated with higher sudden cardiac death risk, especially in pediatric patients. These are all the risk factors, which is these 8 are the standard risk factors for the sudden cardiac death. So depending upon that, we will make the risk evaluation of the patient, and then will be considered for the ICD placement. So comprehensive sudden death risk assessment will be done in the initial evaluation, and after that in follow-up for every 1 to 2 years. So which includes that risk, personal history, family history, and echocardiography or magnetic resonance imaging parameters, and then ambulatory monitoring findings. So magnesium MRI will be used only in uncertain ICD decisions, and then 5-year risk. Sir,
you are going on and on and on. This is not a DM cardiology seminar, man. Assessment is all right once you got the actual things, and then you have to go quickly on to how do you decide when and how to operate, and what things to do. This is going on and on. Now come to the management part of it, and then quickly do. This is the surgical seminar.
Yes, sir, going to. So management of the symptomatic patients, pharmacologically, first line therapy is beta blockers, that is metoprolol and propranolol, which are non-vasodilating beta blockers, and alternatives are calcium channel blockers, that is verapamil and diltiazem. And third one, these are the new addition, that is myosin inhibitors, mavacetam, which are for adults only, and disopyramide, and septal reduction therapy. Contraindications: avoid verapamil in severe dyspnea at rest, and children in less than 6 weeks of age. So summary: beta blockers are the cornerstone of pharmacological therapy, and escalate to calcium channel blockers, myosin inhibitors, or septal reduction therapy for refractory cases, and tailor therapy to patient specific needs, and avoid agents that may worsen alveolar symptoms. So invasive treatment, that is septal reduction therapy or surgical myectomy, is the primary goal is the relieve left ventricular outflow tract obstruction, and then to improve symptoms in patients which are unresponsive to guideline directed medical therapy. So coming to the
hold on. When do
yes.
you decide that the patient is unresponsive to medical management? That is more important. When do you decide that this needs intervention? How long you will give medical treatment? When you decide that this is not responding, and then when you will go on for a further intervention? These are more important practically, rather than going on and on about 1 year follow-up, 2 3 year follow-up, 5 year follow-up, and things like that. So you give pharmacological therapy, not responding,
Yes,
for how long you will wait, and then go on to the next thing. It's a practical approach.
So patients with hypertrophic cardiomyopathy, one is their obstructive physiology with symptoms. We will start with medical management, beta blockers and verapamil or diltiazem, and then if symptoms persist, next level of management is myosin inhibitors and disopyramide, and then third one will be the septal reduction therapy. Timing, how long I don't know, sir, but
That is the
maximum.
most important thing. When will you assess, and when will you send a patient for septal myectomy? Or if that is not going to be done, when will you do surgical management or Moro procedure? You have to decide on these sort of things. These are practical things in managing a patient. This whole seminar will be a waste otherwise. You're going on saying ECG so many times, echo so many times, MRI, angio. You are going on investigating only. When are you going to treat this patient? The practical approach should be done. So you give physiotherapy, medical therapy for so long, not responding. Okay, do the next step. Maybe septal myectomy if it is available, or send him for surgery. How do you decide when to send for septal myectomy? How do you decide when to send for surgical management? And what are the different surgical managements that are available? And how do you choose which one to do when? That is what is the whole idea is to be. Go on. Anyway, you have prepared this. Go on, because you're wasting a lot of time. Yeah.
So septal reduction therapy. So septal reduction therapy, a surgical candidate. If it is yes, then we will be referring him to the myectomy. And if it is not available, then septal ablation will be recommended. So other side of the spectrum, where it is going towards the failure, where LVEF is less than 50, where the patients will be evaluated for the transplant. And if after listing, if decompensated, will be evaluated for the LVAD.
You mean
Septal
Moro
myectomy.
procedure is no longer done?
Moro procedure is done, sir. It is done, sir.
Yeah, okay, go ahead.
Moro's procedure, the procedure involves resecting the hypertrophic septum to enlarge the LVOT and relieve systolic anterior motion. So modern techniques have expanded to include adjunctive mitral valve repair and papillary muscle modifications, and then myocardial bridging release also. So going to the surgical steps, it is showing the multiple pericardial sutures used to suspend the right pericardium into the superior sternal edge. On the left, pericardial suspension sutures are positioned from the aortic annulus to the pericardial reflection, enabling LV apex to descend to the left chest. This maneuver raises the aorta to the sternal level, improving the visualization during the procedure. And then a standard bypass with transverse aortotomy incision above the sinotubular junction to prevent aortic valve distortions. And then we will see we can see the transverse aortotomy is created 0.5 centimeters above the STJ. This approach minimizes potential complications related to valve function. The position of the distal aorta with the pericardial reflection improves access and visibility for subsequent steps. So initial myectomy incision guided by echocardiography near the right coronary leaflet hinge. So figure illustrates that the initial myectomy incision is directed towards the LV apex. It begins 2 mm below the right coronary leaflet hinge point and extends 2 mm towards the membranous septum. The depth and length of the incision are planned based on the echocardiography findings to ensure precision. This allows removal of the obstructive muscle tissue while preserving surrounding structures. And then parallel myocardial incision create a flap for precise resection thickness. From figure we can see a sequence of 2 mm deep parallel incision is made along the LCC and RCC insertions to create myocardial flap of the desired resection thickness. Once the necessary thickness is achieved, the procedure continues deeper into the ventricle, and this method ensures uniformity in the flap and controlled progression of the resection. It also facilitates safe and effective removal of the targeted tissue. So flap resection in LVOT with forceps and incision for specimen removal. The LVOT flap is held and pulled downward with using adjunct and forceps. A second 2 mm deep incision is made along the upper boundary of the initial incision. The subcommissural region is shaped with additional curved incisions, forming a flap. This sequential approach helps achieve the desired shape and depth of the resection. The specimen is removed carefully and separating it from the base, ensuring complete extraction without damaging adjacent tissue. So the final this image shows that myocardial muscle bundles originating at the specimen's base are often divided under traction. The lateral edge of the resection near the mitral annulus is carefully completed using scissors to prevent damage to the submitral valve apparatus. Once these steps are performed, the specimen easily removed through the aortic annulus. The dimensions are then measured to confirm the adequacy of resection. Sparring in the outflow tract caused by repeated systolic anterior motion is typically observed, and at least 1 centimeter beyond the surgical SAM contact point should be resected to ensure adequate relief of obstruction. So here we can see in relation to the aortic valve root. This is the first incision, and then for second incision we will go towards the left coronary and then going towards the apex, and then sometimes it will be extended below the membranous septal area also for the extended relief of LVOTO. And after completion of the myectomy, we can see the base of the papillary muscles, which can be seen easily.
This is a classical operation where the dictum is think twice, measure thrice, and cut once, which we do in most of the surgical procedures. But Moro procedure, this is absolutely necessary. You cannot cut more than necessary. So you have to measure, think twice, measure thrice, and then cut only once. Okay.
Yes. Usually resection will be completed in 20 minutes with a single dose cardioplegia, and the aortotomy closed with 1 or 2 layers according to the surgeon's preference. And then outcomes of surgical septal myectomy in patients with hypertrophic cardiomyopathy in our center, which actually studied between the period of January 2016 to December 2020, where it is inclusion criteria is age above 18 years. And unacceptable symptoms despite a trial of medical therapy, NYHA class 2 to 4, and LVOT gradients greater than 50 at rest or with provocation, and excluded are EF less than 55. Asymptomatic patients are on effective medical therapy for HOCM. Patients with unrelated cardiac conditions other than HOCM. It is showing this is the age distribution of the patients, which shows most of the patients which are about 130 to 60 middle age group, that is 31 to 40 are 25%, and 51 to 60 are 28%. And then gender-wise classification, gender-wise distribution is males are more predominant, which are 70 reaching to, and then females are 30. And then some BMI-wise distribution. Usually BMI influences the symptomatology of the patients. So usually 36% of the patients are overweight, but most of the patients, that is 50%, are normal BMI. NYHA class 2 is 51, class 3 is 42, and class 4 and class 1 are less. So most of the patients will be in class 2 to 3. And most of the patients will classically present or dyspnea, will have the symptoms of dyspnea, and then followed by angina. Other symptoms which they present are palpitation, syncope, giddiness are the very less, and the orthopnea P&D, which are the features of failure, are less. And echo findings wise, the distribution of the patients are estimated septal hypertrophy is the more maximum number of patients, which is 28, and the remaining are a little less, and apical HCM is very less, that is only 3%. This is the range of surgeries which are done for the hypertrophic cardiomyopathy. Mostly it is Morris procedure that is done in 74% of 74 patients, which is the transaortic extended septal myectomy. Other than that, in remaining patients, other things which included are aortic valve repairs, CEBGs, LMAs, and cryoablation, and then LV clot removal, mitral valve repairs, and fenestration of the aortic valve repair. All these things have been done in single cases. So mostly it is Morris procedure which is done in Royal Institute, and interventricular septal thickness during discharge and 6 weeks. So interventricular mean is 21 during this thing. After the surgery it is 16.71, and then in discharge after 6 weeks 16.76, which is showing 20% decrease from preoperative values, which is significant value. And LVOT gradients also, mean is 78, and after that gradients came down to 16 and discharge, and in 6 weeks of follow-up it is 15.85, which is 79% reduction in LVOT gradients after the procedure, which is relieving obstruction, and which actually correlates with the grade of MR also, which actually which shows a decrease in the grade of MR, where 75% of the patients having mild MR in discharge and follow-up echoes. Systolic anterior motion also reduced, where 93 to 94% have no systolic anterior motion post surgery. References are clinical practice guidelines and hypertrophic cardiomyopathy by Srihari S. Naidu, outcomes of surgical septal myectomy in our hospital, and then Kirkland, and then epidemiology of cardiomyopathy.
Yeah, okay. It was an extensive presentation.
Yes.
I didn't know that, the incidence is 1 in 500, which means we are grossly underdiagnosing many patients. But that was something that. But you see, where you, as I said earlier, you went on and on and on about the investigations part of it. That is okay. That comes from the cardiology side and things like that. They follow up these patients.
Yes,
For
yes.
you as a surgeon, you must know when to intervene, what to intervene. So, and you should have focused a little more on septal ablation. What is the material used, how it is done, what are the complications of septal myectomy, how if it spills over into an LAD and then causes myocardial infarction. Those are dangers of septal myectomy. I mean, septal ablation. And secondly, you should have spent a lot more time on the actual surgical management, surgical procedures. How do you measure? Where do you measure? How much to remove? What are the problems? What are the complications of a Moro procedure? You can create a hole, you can create a septal defect, or you can, if it is on the other side, you can create, if you are going to be doing Moro procedure, you don't do the left free wall resection. But if somebody wants to do that, then you have to be very careful how much you're going to remove it. So these are probably should have been focused on, rather than the entire. You spent almost 40 minutes on the pre-op evaluation.